The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody, and welcome to Reproaction's Act and Learn webinar, Attacks on Later Abortion. We are super excited. We have a great panel for y'all today, so let's go ahead and get started. Alrighty, so I will introduce myself and then kick it off to my wonderful co-host. So my name is Jessica Ensley. I use she, her pronouns. I am the Senior Vice President of Outreach here at Reproaction, and I am based in Washington, D.C. And I will kick it over to Kelly to introduce herself.
Hi, I'm Kelly Robinson. I use she, her pronouns. I am the press secretary for Reproaction, and I'm based in Washington, D.C. as well.
Great, thank you. So here's the agenda of our webinar today. I will introduce the organization, and then Kelly will go over our topic for today before we dive into our panel. One note at the top is that you can join our conversation by live tweeting at #Reproaction. And if you have questions throughout the topic overview and throughout the panels, please enter them into the questions portion, and we can get to them at the end for our Q&A section. So to start out, Reproaction leads bold action to increase access to abortion and advance reproductive justice. We are known for our left flank analysis, our willingness to hold folks on all sides accountable, whether they be allies or opposition, and we are committed to nonviolent direct action. Okay, and I will kick it over to Kelly to introduce today's topic for us.
Hello, everyone. Thank you so much for joining. And we will be talking about abortion later in pregnancy and attacks on abortion later in pregnancy in today's webinar. To get started, I wanted to make sure we were all on the same page with terminology. I'm sure many of you are already familiar with this, but for those who are not, the reason that we say abortion later in pregnancy or later abortion versus late-term abortion, which is something you may have heard frequently, is that late-term abortion is not a real medical term. Doctors don't clinically use late-term abortion, so we shouldn't be either. What's more, a pregnancy is described as late-term past 40 weeks. So late-term abortion then deliberately implies that all abortions later in pregnancy are happening around or post 40 weeks, which isn't true. So we should always make sure we use real medical terms and terms that don't dehumanize patients and providers. As far as when exactly is later in pregnancy, at this time, there isn't a specific point in a pregnancy that all experts or doctors would say qualifies as later. But if you look at studies and surveys on the topic, they tend to look at pregnancies occurring later in the second trimester or beyond. Right now, these represent about 1% of all abortions in the United States, but that number is growing. So reasons for people that have abortions later in pregnancy, I'll give a quick overview here. A lot of information on this topic comes from one of our excellent speakers, Dr. Katrina Kimport, from her extensive research and interviewing. So she's able to provide even more depth and context on this topic. But as an overview, one of the reasons that people might have abortions later is that they have a delayed discovery of their pregnancy. Not everyone gets the stereotypical pregnancy symptoms like feeling nauseous or craving certain foods, not tolerating others. And some people don't get any pregnancy symptoms at all. A missed period can't always signal pregnancy since many people don't have regular periods to begin with. Medical conditions, including polycystic ovarian syndrome, thyroid disease, and perimenopause often cause irregular or infrequent periods. In many people, hormonal birth control can cause periods to become less frequent or even completely stop while they're using it. So if you don't have pregnancy symptoms and infrequent periods are what's normal for you, it can take a while to realize that you're pregnant. According to the Cleveland Clinic, 1 in 475 pregnancies are unnoticed until 20 weeks. While that's a small proportion and it may not sound like a lot, when you consider that there are millions of pregnancies every year, that is actually quite a good number of people that can apply to. The cost of abortion itself and the cost associated with traveling for an abortion if you can't get one locally can also lead to delays. The median cost of a first trimester abortion in 2021 was $625, with costs rising as the pregnancy progresses. So it may take weeks or months for an abortion seeker to get the necessary funds to get the care they need. As of 2023, the average American lived 86 miles from their nearest abortion provider, with 14% of people living more than 200 miles away. So if an abortion seeker has to take time off work, which they may not be paid for, stay at least one night in a hotel, and possibly find childcare, which they may also have to pay for, this makes it even more challenging to get an abortion quickly. Abortion bans with gestational limits and fewer clinics equipped to provide later abortions can make it even more challenging for people to get abortions the further along their pregnancy goes. And finally, new discoveries about their health or the health of their pregnancy could prompt someone to seek an abortion later in pregnancy. A number of fatal or serious fetal conditions that often can only be discovered in the second trimester, often after the 20-week anatomy scan. And in many cases, there might be several follow-up tests and scans necessary to really confirm a diagnosis that enables a patient to make a decision. Conditions that threaten the health of the pregnant person could also develop or be discovered later in the pregnancy as well. So attacks on abortion later in pregnancy, it's difficult to obtain an abortion later in pregnancy, or it can be. Only 7 states and the District of Columbia allow abortion throughout pregnancy with no gestational limits. There are 14 states that completely ban abortion, and the remainder are somewhere in between where they allow abortion, but there is a cutoff around different points in pregnancy. So if you're looking for an abortion after that, if you need one after that, you may then not be able to get it where you live. Ironically, jobs could lead to more abortions taking place later in pregnancy, as people living in states with abortion bans may have to delay care until they're able to travel out of state for an abortion. Out-of-state travel for abortion care doubled in the first half of 2023 compared to the same time period in 2020. Another major attack from the legislative side on abortion later in pregnancy are what are called born alive bills. These bills are predicated on the idea that people can and do get abortions, quote unquote, after birth, which they don't. These bills are all different, but generally require doctors to provide medical aid to any baby born after an unsuccessful abortion, which is something doctors are already bound to do. These bills are meant to mislead the public that infants that are born after an unsuccessful abortion are either killed or denied any form of medical care, with the intention to vilify abortion providers and abortion seekers. Federal anti-abortion leaders have been trying to pass the Born Alive Survivors Protection Act since 2015. The House most recently passed it in 2023, but the Senate hasn't taken that up. At the state level, these laws have gained more traction. Just this year, 28 such bills have been introduced, but none have been passed or enacted yet. Last year, there were 38 introduced, and 3 of those were enacted. In 2022, 33 were introduced, and in 2021, 36 were introduced and 6 ended up being enacted. So now we'll turn to today's panel. So we have some excellent researchers who have studied abortion and abortion later in pregnancy, starting with Dr. Katrina Kimport. She is a sociologist whose research focuses on gender, health, and reproduction, with a focus on people's experiences of seeking and obtaining abortion. She's the author of No Real Choice: How Culture and Politics Matter for Reproductive Autonomy. Thank you for joining us, Katrina. So you've been researching abortions later in pregnancy for years. What motivated you to make this one of the focuses of your research? And is there anything you found in your research that you think people would be surprised to learn about later abortion?
Hi, Kelly. Thank you so much for having me. And thank you for that really excellent overview of the topic to start out with. I realize that my slide information doesn't include that my pronouns are she, her, so I want to add that in. All right, so let's see, how did I first become interested in this topic? A lot of the things that I'm interested in as a researcher are the places where we don't actually have a lot of empirical information, but people think like there's a general lay understanding or a general belief in the general public about a meaning of something. To put that into the specific case of thinking about later abortion, one of the things I noticed when I first started entering into thinking about this topic in about 2016, so a little while ago, was that there was a huge amount of overlooking the population of people who have abortions later in pregnancy in research studies, and often intentionally so. So fantastic studies like that of my colleague, Diana Foster, who led the Turnaway study, explicitly excluded people who were seeking an abortion later in pregnancy who had a diagnosis of a fetal anomaly. And the presumption there was that there was something qualitatively different about that experience. And I also saw a similar sort of treatment of certain kinds of abortion, particularly abortions later in pregnancy, as qualitatively different in a lot of the public conversation about abortion. So an assertion that everybody is uncomfortable with this, it's always terrible, that it is something where there would be sort of common ground and that it's a reasonable thing to agree that it should be severely restricted and even banned. So when I see situations like that where there's a collective agreement, often across otherwise positions that are in conflict around a topic, and also a lack of actual empirical data to support that, that's where I get really interested. And so that's where I started first trying to think about and being interested in understanding the process and experience of seeking and obtaining an abortion later in pregnancy. And there was just a huge gap in the literature, which I am so pleased has been steadily, by not just me, but loads of other scholars, steadily worked to close that gap. I think that the main thing, so that's sort of what my motivation to first enter into this topic. Perhaps I've been surprised that it has been such a continuously rich topic to be thinking about and working in. One of the things that was unexpected but really rich opportunity was that the experiences of people, again, remember I started thinking about this in 2016, did my first data collection on the topic in 2018. So the Dobbs decision was not even a possibility yet. And what has been really surprising and fruitful is that in many ways, the experiences of the people who sought an abortion later in pregnancy before Dobbs, the needing to travel, what those emotional experiences and costs were, ends up actually being a preview of what many more people are experiencing at all different stages of pregnancy in the post-Dobbs environment. So what was really a sort of a surprising thing was how much of a preview that offered for the landscape we are now experiencing.
And very few states allow abortion with no gestational limits, and even some states that are in some ways more protective of abortion still ban abortion after, as they say, viability. Can you discuss the problems with using the idea of viability to restrict abortion access?
Sure, and thank you for that question, because this is, I think, a question that many people couldn't even imagine even a few years ago, right? Like the ability to articulate this as a question was just off the table. So having the imagination to be able to think about this is pretty new when we think about reproductive justice efforts, and I welcome it. Viability limits are abortion bans. That means that they serve to delay and deny abortion care to people who want and need it. The way that viability limits, I'll call them, although really what they are is a ban, the way that a viability limit is written in the law is one of the effects of that is that it asserts that there's a point in pregnancy when somebody other than the pregnant person or those who have a social relationship to the pregnancy. A point in pregnancy when people outside of the pregnancy can deny abortion. And it's built around a fetal development marker. So it's fetal-centric logic for deciding who may have an abortion. And very importantly, it doesn't account for the pregnant person's viability. It was very common in the early years when abortion became decriminalized, before Roe established a federal constitutional right for abortion, for there to be abortion, a therapeutic abortion under the logic of sort of emotional or mental health harm. And there's been evidence that that was probably a little bit generously used, shall we say, as a way of navigating what was allowable. But even if that was perhaps more than maybe was clinically representative of people's experiences in pregnancy, it didn't mean that there were never instances and are never instances where the pregnant person's viability for mental health reasons, for their physical health, may be compromised or put in severe jeopardy by continuation of a pregnancy. And a viability law does not account for that in terms of the mental health. And while it has typically exceptions for the life of the pregnant person, that's not quite what we mean by viability often. One of the other limits of the way the law is written around viability is that it's really quite a blunt tool, right? Viability is defined quite narrowly, and it may be defined even as bluntly as the live birth, which doesn't say anything about the health or quality of life that that baby is going to have. And it's defined in a way that doesn't include the pregnant person's beliefs and understandings about what kind of life they would like to offer their baby. And all of that is just at the level of the way the law is written. In practice, what we've seen is that viability limits work as a de facto gestational limit, so that states that have a viability limit tend to, or providers in states with viability limits tend to simply stop offering abortion care after 24 weeks. So people I interviewed who had a serious fetal health issue might still be denied an abortion after 24 weeks in a viability state, just because the way that that law had been interpreted in practice was as a gestational limit. So one of the things that we can see here is that really just the idea of a viability limit is a way of banning abortion that then just bleeds into all different ways of practice that just further limit access to abortion.
And in your research into people who sought or obtained later abortions, what are some of the trends you've noticed and observed about who needs abortions later in pregnancy and why?
I think that to sort of circle back to the way that you excellently introduced the topic in the outset, that I usually think of it as just two categories. So there's new information, and that includes finding out that you're pregnant later in pregnancy, right? Like that's new. That's something that we can't reduce. We can't science our way out of learning about fetal development earlier in pregnancy. People have tried to identify interventions to help earlier recognition of pregnancy, and those have been unsuccessful. The place in terms of barriers, so people who are often their policy barriers, but there are also a set of barriers that are more idiosyncratic. There was somebody I interviewed who was effectively kidnapped by her mother, who had some mental health issues, and was unable to make it to an abortion clinic until after the 24th week of pregnancy. So this is something that, is not a policy related barrier per se, but was a barrier in her being able to access care. One of the things I think that we're seeing is, as you noted at the outset, an increase in the people who fall into that barriers category. The people who fall into that barriers category, the people who are going to have difficulty finding a provider, finding the money for a provider, finding the money for travel, being able to take off work, sort out the logistics of childcare for existing children or other responsibilities they have. Those are people who are already typically in socially marginalized situations. They are people who are financially struggling. And I think that that is something that we're seeing grow more and more.
A dearth of providers, even in states without any gestational limits on abortion, can make it harder to obtain an abortion later in pregnancy. What sort of education, training, or policy changes are needed to help raise the number of providers who are able to offer abortions later in pregnancy?
I think this is a fantastic question, and one that many people have been grappling with. You know, as I think has sort of been implied in the way that we've talked about this so far, even though we have, you know, a small number of states where abortion throughout pregnancy is legal, there are even fewer where it's actually available. So already there are policy-friendly environments where abortion later in pregnancy is still not available. So what this means is that we have a very small number of providers. So that means any shift, right? If one person closes shop, it can make a really huge impact in availability. So thinking about how that workforce and availability can be expanded is a really key important question for ensuring access for the people who need abortion later in pregnancy. The education and training are available. They're there. You know, it may be there are people who are available to train new providers. So that is something that sort of exists. One of the biggest challenges is the will, the interest. Right now, it is very difficult in many places to open a new clinic. Some of you may have heard of in Los Angeles and Beverly Hills, the DuPont Clinic, which already has a location in Washington, D.C., wanted to open a location in Beverly Hills. And despite the Beverly Hills Council publicly expressing their support for abortion rights following Dobbs, there were a number of actions that led to the landlord of this space ending the lease. And so this clinic has not opened. I think they're currently in litigation. So I think we see this sort of on the ground complexity that happens in abortion care broadly and is just heightened in terms of the sort of built-in controversy and political challenges around establishing these providers and clinics. I know I'm over time, so I will just make one last note, which is that what we have seen, which is a really fascinating and encouraging trend, is that there are a number of clinics throughout the country that pre-Dobbs were offering care to, say, 22 or 24 weeks that have revisited their gestational limit and are now offering care to 26 weeks or 28 weeks. This is not throughout pregnancy, but it is still a really significant change. Many of the people who maybe, if they couldn't get an abortion at 26 weeks from this clinic, might end up far later just because of the additional delays that they might experience in trying to get to one of the other existing providers. So I think this is a trend, a positive trend towards increasing and expanding access, but there are a number of very significant and complicated, often political barriers to doing it at an even larger scale. And thank you so much.
Thank you so much, Katrina. We'll move on to our next panelist, Sarah Baum, a senior research scientist at IBIS Reproductive Health. Sarah manages a portfolio of work addressing access to safe abortion and reproductive health care As an expert in qualitative methods, Sarah prioritizes developing research questions in partnership with clinic and advocacy partners to gain a deeper understanding of the preferences, priorities, and experiences of people seeking and obtaining abortion and contraception. Sarah has published and presented on work assessing abortion-related stigma and quality care among providers and women, evaluating use of medication abortion in legally restricted contexts through a range of care models, and documenting the impact of restrictive abortion and family planning laws. Sarah received her undergraduate degree in psychology from Lewis and Clark College and a Master of Public Health in Reproductive and Family Health from Columbia University's Mailman School. Sarah, thank you so much for joining us. And how did IBIS's Later Abortion Initiative originate, and what are some of the goals?
Thanks, Kelly, for having me. It's great to be in this space as well with you, Katrina. So yeah, I'm happy to get to share with you a little bit about how the Later Abortion Initiative, or I'll call it LAI, started and what our goals are. Back in 2007, there was a partnership between IBIS Reproductive Health and UCSF Answer that gathered together a group of experts to identify recommendations to improve second trimester care around the country. And that group worked together to put out these recommendations and to continue to work with different experts under the umbrella. But it became clear over time that there was a need to expand the work beyond just the second trimester into the third trimester. So fast forward to 2015, the Later Abortion Initiative became a project under IBIS Reproductive Health, and we aim to address issues related to high quality later abortion access. Our focus tends to be, as was mentioned, in the later second trimester and third trimester of pregnancy, although we don't use trimesters very often in our work. I invite you all to go to the laterabortion.org website, although I will note that we're preparing to do a content update and give the site a nice makeover, but there are some gems on there, including some of the great research that Katrina has done and other researchers in the field. So I would say that LAI's goals fall mostly into three buckets. The first is clinical research and projects. And here, LAI aims to support innovative approaches to expand access to later abortion care in the US through research and partnerships. And I'll just highlight a couple that we're working on now or recently. And most of these ideas come to us from providers or from advocates like practical support organizations or abortion funds who are seeking information and ways that we can support them to do that. So one is documenting how providers offer later abortion care at 24 weeks and higher. There are many different ways that they do it, and the providers came to us and said, hey, can we document these different strategies, particularly related to the preparation for D&E? So this might be cervical priming, among other aspects of their technical care. So we're working on that. We got called by a provider in Alabama who said, hey, I want to document the innovative cervical priming method I'm using, which at the time was the fully ballooned catheter and misoprostol, different than many other providers. So we worked with them to measure the safety and effectiveness. And yet another example was a provider in the Southwest who wasn't offering D&E for their later abortions, but was offering medical induction in an outpatient setting. So we worked with them to understand how their providers were feeling about that technique and what the patient experience was. So in addition to some of those clinical research pieces, we've also heard, and Katrina talked a little bit about the training is out there for providers, and I do agree with that. But we heard from people that it was really hard to travel and go and get the training they wanted from seasoned providers to expand their gestational age. So they already had the techniques that they needed to go to the gestational cutoff they had, but they wanted to expand that post-jobs. So we worked with providers to create what we call the incremental expansion of abortion care curriculum. This is just a didactic written curriculum that people can download, but then we also created listservs so that people can join together and ask each other questions. These are for people who want to go from, say, 13 weeks in pregnancy to 17 weeks, or later from 23 weeks up to 26 weeks. So these kind of smaller jumps in gestation at their existing clinics. So that's the bucket of clinical research and projects. The second goal of LAI is evidence sharing. Here, we hope to disseminate evidence-based information about later abortion to a range of audiences. And again, this isn't just research produced out of LAI, but from researchers across the field. So on our website, we have fact sheets and briefs. We aim to incorporate information from outside the country too, that might be able to inform US-based practices. And then we also work to identify gaps in the evidence and bring people together to address that for later abortion. And the third bucket is convening. We see it as critical that people whose work is touched by later abortion can join together in the same spaces to share information, to ensure coordination of efforts, to catalyze collaborations, and those might be virtual or in person. So we host the Later Abortion Network, which convenes staff from practical support organizations, clinicians, lawyers, advocates, researchers, and others to discuss relevant information about later abortion care. And then we'll also gather people in in-person convenings. For example, at upcoming conferences, we'll get the providers who offer third trimester care to kind of cross-pollinate with each other. So that's a little bit about LAI and our goals.
Thank you for sharing that. And can you discuss how gestational limits or bans on abortion may pressure pregnant people to make a decision about whether or not to seek an abortion, especially when the pregnancies may be discovered later or they get new information about the pregnancy?
Yeah, thanks for this question. Before I jump into how it might pressure people, I do want to just sort of lay out an affirmation that I think has sort of been said already, but LAI very strongly believes that people deserve to have an abortion throughout their pregnancy when they want, at an affordable price, without judgment, and ideally close to home, which, as Katrina already talked about, is challenging and has been challenging before dogs for people seeking later abortion. And that every pregnancy is unique, and so the government shouldn't be intervening in creating these gestational limits or viability limits. And recent polling has shown that actually most people in the country do not want these limitations on abortion. So I just want to sort of lay that framework as I answer this question. That said, we do know that there's these wave of bans and limits that are sweeping the country post-Dobbs. You mentioned there are some states that have no limits on abortion, but we see 14 states with full bans and then 27 states who have bans at some gestational duration. So that's 7 states under 18 weeks gestation and 20 states who have some limit over 18 weeks. And these bans and gestational limits can cause harm and drastically limit options for later abortion care for those that are recognizing their pregnancy later, discovering issues later, or really for any reason seeking later abortion care. And if we imagine being in that place and having to make decisions, somebody who's late enough in pregnancy that they can't order pills online, right? They're going to have 3 options. You have the option to travel, unless you happen to live where there's a later abortion clinic. Most people would have to travel for that care. You have the option to, or you may be forced to feel like you have to self-manage your abortion, which raises issues of criminalization, or you continue the pregnancy. So what impact do these gestational limits have on people who are in the midst of making choices for themselves within those options, or forced to make choices within those options? One impact is urgency. We see people pressured to make decisions before they're ready. Perhaps they don't have all the information to make the right decision for themselves. And even if they've made the decision to go have an abortion, they may be impacted by the urgency that persists throughout that experience related to gestational limits. In addition to urgency, we also, people may be impacted in how they feel about themselves and what they're doing, right? So their religion, their family, their social situation may make them feel certain ways about having an abortion or not. But these gestational age limit bans also can bring about feelings of stigma and fear of criminalization. So while we know that the laws mostly don't punish abortion seekers, but actually punish providers for offering care outside the law, these bans can be confusing for abortion seekers. They can make people feel like they've done something wrong, and they can fear criminalization, especially depending on who they are. So urgency, this piece about stigma and fear of criminalization, and then really these gestational limits can exacerbate challenges of access that existed without them. So Katrina talked about some of the pieces related to being forced to travel. And for many people, even if they've had an abortion in the past, they may be traveling to unknown places. There may be new circumstances surrounding their abortion. So they're navigating often something new, even if they've had an abortion in the past. You know, we talked about logistics, we talked about the financial pieces, we talked about the planning with the clinic. So these are all pieces that people have to figure out under the urgency of a gestational age ban. Once they're on their way to care, there are other challenges with that urgency, right? Do you know where you're going? Do you get lost? Do you have enough gas? Are you feeling any sort of emotional or physical discomfort? And then the recovery coming back through travel. So those are some of the impacts on people seeking abortion. And with this question, I also just want to take a minute to highlight the pressures on the small number of existing abortion providers that offer later care in pregnancy. As Katrina mentioned, there's limited, geographical spread of these clinics. You can imagine they tend to be on the coasts, save for a couple of states in Colorado, Illinois, in the middle of the country. And LAI does offer a public referral list for people that offer care at 24 weeks and above and are willing to be listed publicly, of which there are 14. So the burden also falls of these gestational age limit bans on these small group of providers as well.
Yeah, and post-labs, what are some of the gaps in research and evidence around abortions later in pregnancy?
As Katrina mentioned, people have taken up this topic of later abortion and are really starting to fill some of the gaps. So I'll mention a few that we've been hearing about and would welcome anyone who is on the webinar and sees a gap in research or an area you wish was better understood through the literature. LAI is always open to hearing from others about what information they feel like is missing. A couple of things I'll mention. So post-jobs, there continues to be a question about how many people are seeking later abortion care. So I think there's a common understanding that that jobs in some of these state bans have pushed more people to seek abortion later. And we see that written all over, but we actually are missing some of the empirical evidence to back that up. So there are some researchers starting to look at gestational age trends over time, either by state, across the country, or even within a high volume clinic to see how their gestational age trends have changed over time. In the opening presentation that so nicely laid out later abortion, you mentioned the statistic of 1%, which generally comes from the CDC, and there are many states that actually don't send their numbers of abortions to the CDC, so it doesn't take into account where all the later abortions are happening. So the guess is that that number is actually higher, but we don't have that number to offer. And what would that number do? Knowing that more people are having later abortions may be influential for how funding gets delivered to some of those care models and the ways that it shows up in advocacy in other areas. Another area is the role of hospitals. In abortion care, we often kind of put to the side the provision of abortion in hospitals, and indeed, early in pregnancy, hospitals make up a very small proportion of abortions. But the hypothesis is that that's not true for later abortion, and in fact, post-jobs, it's likely that more people are receiving care in hospitals, but we don't know who exactly is providing, what their volumes are, and what the patient experience is, where the areas are for improvement in that. So that's another area of potential research. And then documenting the ways that providers have expanded their care. There's so many resilient providers doing work to get more people in and to go up in later gestations with creativity and innovation, and documenting some of that has to come directly from the providers. So that's of interest as well. And just to name two others, the innovations that those providers are doing, such as shorter procedures. So, a later abortion can be up to 3 days long, and providers are working really hard to see how they can limit that to reduce the burdens of travel and overnight stays. And then there's coordination happening between providers that are in states without bans or with fewer limitations and banned states. And so documenting some of that so that other providers can learn from that can be really useful. And the last thing I'll mention is the amazing support of abortion funds and practical support organizations in this changing legal landscape to get people to the care they need. And there's research to be done to document that work and celebrate the resilience of the people who are working with those groups as well.
Abortion bans and restrictions of any kind often hit lower income people and people of color especially hard. What impact does the difficulty in accessing abortions later in pregnancy have on marginalized groups?
Yeah, thanks, Kelly. So like so many other access issues in sexual and reproductive health, the delays and barriers to abortion do indeed hit hardest on the people who have faced oppression in the healthcare system, who have faced systemic racism, who have limited financial resources or are over-criminalized. And of course, abortion seeking doesn't happen in a vacuum, so people bring all their identities and their circumstances to the search and access of later abortion. I want to highlight here interviews that we did with 30 practical support organizations. And when I use that term, my guess is most of you know what that means, but those are the people that are helping people get rides, that are paying for their train ticket, who are coordinating where they can stay if they don't have a place to stay for multi-day procedure. Really helping somebody kind of case manage and work through the logistics of getting to later abortion care. So we did 30 interviews with people who work at those organizations and other advocates who help later abortion seekers. And they, along with other literature that's published, have highlighted that the extra burdens fall not only on low-income people and people of color, but particularly Black people and Native and Indigenous peoples, but also undocumented folks, transgender and gender expansive people, those living rurally, people under 18 or minors, those experiencing violence in their home, and those who are unhoused. So these are some of the groups when we said, who is it that you find face the most burden that were mentioned in their care? So how does the difficulty accessing later abortion impact people? You can think about the sort of more acute abortion-related impacts. This can contribute to further delays in care, negative feelings about themselves or stigma, potentially accessing lower quality care due to a lack of accurate information, or challenges with follow-up care if they don't have access to the internet or a private phone. And truthfully, the potential inability to access their desired abortion. And here, the practical support organizations encourage us to think about people who might not have an ID, or their ID doesn't match their pronouns, or it doesn't have their name on it, the name that they use, that might not have a credit card, which makes staying overnight really challenging. There are language barriers to accurate information, challenges with internet access, or not having a privacy when you go home, say you live at a homeless shelter. So these are some of the kind of more acute pieces, but they can have implications for people's lives going forward. So say you're using your financial checks, or you had to take out additional subsidized loans at school to pay for your abortion, that can impact your interest down the line and the ways that you're going to be able to kind of pay for your education going forward. And Katrina mentioned the Turnaway study, but I think it's important to mention that we know that if somebody isn't able to access their desired abortion, in fact, they are worse off down the line, according to Turnaway results, such as more likely to live below the poverty line, stay with an abusive partner, or suffer adverse health events. And ultimately, those that are not able to decide if and when they want to have a family, including their desired abortion, are not able to practice their reproductive autonomy or thrive. So those are some of the impacts. Before I kind of leave this question, I do want to leave us on a positive note, which, you know, these difficulties are many and they do impress upon certain people more than others. And there are exceptional abortion doulas, non-medical support providers, abortion funds, healers, caretakers around the country who are supporting people within their communities to get the abortion care that they desire, to make sure that they know they deserve quality care, and to stop and just listen to them and hear what kind of abortion experience they want. And it's these pieces of support that can have a positive impact beyond the abortion, in addition to some of these more negative pieces.
Thank you, Sarah, and thank you for lifting up those resources as well.
Great. Thank you to Sarah, and thank you to Katrina so much. for answering our questions. I'm going to head next into a couple of housekeeping items, but welcome any of our attendees to enter in their questions now as we get to the Q&A portion. So you can plug into Reproaction campaigns by signing up for alerts at reproaction.org, and you can follow us on social media, Facebook, Twitter, now X, Instagram, all with Reproaction. And save the date for our next webinar, which is Algorithmic Surveillance and Abortion Access. That's going to take place on Thursday, July 25th at 2 p.m. Eastern Standard Time. All right, so moving over to some additional questions. I want to ask this question first to Katrina. I was wondering, how can we have discussions about abortion later in pregnancy that combat the attacks and disinformation coming from the anti-abortion movement?
Well, I mean, that's an excellent question. And I feel like almost all of your questions I should be calling the $1 million question, because they are the things that I would like to have solved. I think that the most straightforward way that for these particular set of questions, and often for the broader attacks on abortion rights, abortion access that are coming from the anti-abortion right, is to really center the experience of pregnant people and abortion seekers who are attempting and when they are successful. What I've found in conversations, say with reporters who are trying to navigate between anti-abortion rhetoric and reproductive justice advocacy, and are talking to me, that the place that really seems to sort of navigate those, successfully navigate those competing claims, especially the misinformation-based claims, has to do with really rooting it in real people's experience. So one of the things that we know is that when we, and this has been true for decades, is that public opinion polls show a great amount of support for abortion under certain circumstances, and also have historically shown very low support for abortion later in pregnancy. Clarifying for people that many of those circumstances that are generally publicly not just acceptable but supported are also circumstances that may be more common, but at the least occur later in pregnancy, has been a really interesting shift in the way that conversation has happened. I think the other piece that's sort of connected to this is when you root it in actual abortion seekers and you root it in their experiences and focus in on their emotional experiences, things like I actually was talking to a reporter the other day about a Born Alive bill that's happening in one of the states. And one of the people that I interviewed, she was in a state, this is somebody who had a third trimester abortion. She was in a state where there was a Born Alive bill on the books, which meant that she felt like if her desire was actually to continue the pregnancy, to give birth and offer palliative care to her baby, to be able to meet her baby and to be able to prevent future suffering. But her state's Born Alive law, as she understood it and was told to her by providers, meant that all interventions would be required to be performed on her baby, which would not change his long-term outcome, but would lead to what she believed to be greater suffering. And so she sought an abortion. And I think that the political rhetoric would regularly want to distinguish these as, well, first would often ally the existence of these actual experiences, but likes to set up as a sort of a conflict between birth and abortion. And so often when we can focus instead on real people's lives and their decision making, we can see that the nuance and the complexity mean that what is already a complicated, sometimes emotionally challenging experience is being made more so by these policies and by this rhetoric. And that is, to me, one of the most successful ways to upend and destabilize a lot of these really bombastic anti-abortion claims.
Wonderful. Thank you so much for sharing that story, and rooting these issues and how they truly impact people's lives and their reproductive freedom, or lack thereof, is a really powerful tool. I just wanted to pass it over to see if Sarah had anything additional to add before we move on to our next question.
Yeah, that's what I was thinking of first as well. I was thinking about storytellers and the power of those that are comfortable sharing their story, kind of being centered in how we think about later abortion. So I completely agree with what Katrina was saying.
Wonderful, thank you. So we have a question from Twitter. I don't know if Sarah or Katrina will have an answer, but do we know how many countries globally have no gestational limits on abortion care?
Sarah, I don't know if you know. I don't know off the top of my head. I think that there's a balance between whether or not there is a policy and also whether or not there's actually a provider. So I do know that there are locations in the United States that receive patients globally. For example, Canada has through their national healthcare system, offers abortion under certain circumstances throughout pregnancy, but actually doesn't have the capacity in many of its provinces to offer that. And so will support paying for patients to actually come to the United States for their care. So it's a great question. And I don't have a firm answer to it. Sarah, maybe you know?
I don't actually either know off the top of my head, but I agree that I am constantly looking for ways that we can learn from provision and care that's given abroad for what's happening in the US. And I think this question aligns well with that, but I don't actually know how many countries.
Yeah, thank you both. And I think it ties in well to what was said previously on this webinar, which is just because somewhere it is on the books legally does not mean that there is that access to it. So might not necessarily correlate either. Sarah, I want to kick this next question back to you. So we've talked a lot about some of the rhetoric around abortion later in pregnancy, but are there any additional misconceptions that we haven't gotten to or that you would like to dive in deeper to dispel?
Yeah. This kind of connects back to your other question for Katrina about how we can have these conversations. I think language really matters in these conversations. And at the top of the webinar, you talked about late-term abortion and how I think the field really successfully has moved away. Even in media, we've seen movement away from that. But we'll submit papers to journals and they'll say later abortion, what are you talking about? And so being really clear about why we're using the language we're using. And one of the organizations that I think is doing really excellent work around later abortion is Patient Forward, and I would encourage people to look at their work. Part of what they do is thinking about messaging and how it can be stigmatizing and misleading around abortion and specifically later abortion. And they talk about abortion throughout pregnancy or up to birth, and moving us away from trimesters. So just kind of going back to that question, I think really thinking within our field about the language we're using and how it may impact people can be really critical. I think consistently right now there's a lot of narratives about how hard abortion access is, and I think we all know that is true for so many people. Getting a desired abortion has been made harder. But I do want to kind of raise this point up again about the support that people have access to. And, this is part of why documenting people's experiences or changes in abortion numbers can be challenging, which is there's incredible resilience out in these states to get people connected to care. And I think, we haven't said it specifically, but it can be tens of thousands of dollars to get a later abortion. And the groups that support people to kind of raise those funds and figure it out are critical to reducing the number of people that wouldn't otherwise be able to access their abortion. So, you know, we can see some of the ways that the systems are working to support people, and then underneath that, where we're able to see are many other systems at work to get people to the care that they need.
Thank you.
And if I could just build on Sarah's points too, would that be all right?
Oh, yes, please. I was just about to kick it over to you.
Okay, great. Oh, wonderful. I read your mind. I think that to build on Sarah's point about the importance of language, I think to sort of expand out from that and thinking about the precision that we can use when thinking about what is unique about later abortion and what is not unique. So one of the things that my research has really underscored, and I think that you can see in the storytelling, in the advocacy language, is that the decision making, the certainty of people's decision is not different based on what point in pregnancy they decide they want an abortion. And so that it's not harder or easier because of gestation, that those are about social circumstances and where the pregnant person finds themselves. There are, however, some differences clinically based on what somebody's gestation is. And then there are ways in which the landscape of abortion availability can make seeking an abortion and obtaining an abortion very different. And so being able to talk about what things are different and what things are consistent throughout pregnancy, I think that that's also a really important part of expanding our conversation and expanding the way we think about abortion that best captures people's real experience and best forwards the principles of reproductive freedom and justice.
Wonderful. Thank you for that thoughtful response, Katrina. Our last question, and I want to keep in mind we only have a few minutes left. Katrina, Sarah, whoever wants to take this one, please jump in for it. It is, how do you balance the concerns about patient data privacy and getting accurate accounts of abortion performed throughout a pregnancy? Great question.
I can step in and then I'll pass it over to you, Katrina. This is a critical part of how I think about research at every step of the way, whether we're doing later abortion research, work with people who self-manage their abortions, the need to protect the people accessing abortion. And this isn't just the person that might participate in a study, but also includes, you know, by highlighting a certain type of care or a certain type of support or an area where people are able to access abortion, by putting that into the public space, how does that put people at risk or cause potential harm? And in my research, this is a constant tension. So how do we make sure the information is present and also protect people? And so I will just name two things that IBIS, Reproductive Health, and LAI think about. One is partnerships. I think the best people to keep us in check about what potential harms there are and where people need privacy and support is to work, you know, sometimes with people who are seeking abortion, but more often with the groups that support them to get abortion and are based in their communities, to consistently check on, here's the research question we are seeking to answer, and here is what we may find, and tell us about the harms. That said, numbers can be really important because they drive funding, they help think about policy decisions, they help think about advocacy, and so we want to do our best to collect those things. And I think doing it responsibly and working in partnership can be really important. And then also anonymizing where necessary so that we remove sort of the specifics while also providing kind of the takeaways and importance of the numbers. I don't know if you have other additions.
I'll build out and talk about too the sort of the question around medical records, and this is one that I think sort of anticipating maybe the next webinar, but there is a big question about what goes in electronic medical records and patient privacy, especially when they're moving back to their states of origin where abortion may be heavily restricted. What we do know when we're thinking specifically about later abortion is that the way that that procedure or intervention was categorized and classified in medical records already was not the same. There was already huge variation in the classification on medical records pre-Dobbs. So this is, this is a fascinating situation where you have the social and political contention really bleeds into a whole way of understanding medical care, which then circles back by affecting even those seemingly straightforward counts that then go back into those social and political discussions. So I think this is something a lot of people are very sensitive to and thinking about very seriously, and trying to balance the importance of getting accurate measures against the concerns around patient risk. And we'll see how that continues to sort out.
Great, thank you so much for explaining that, Katrina and Sarah. Thank you to Kelly for putting this wonderful webinar together. Thank you so much to Katrina and Sarah for taking the time and lending your expertise on such an important topic. And thank you all to all the attendees for joining in and listening. And I hope you all have a great rest of your day. Take care, everybody.